Welcome, everyone. I'd like to welcome everyone to the Senate Committee on Rules, Government Ethics, and Oversight. This is our first meeting for 2021. Quickly going to address our agenda for today. We have two items on our agenda. Our first presentation will be associated with the Health Services Council, overview of duties and responsibilities. And we're fortunate to have Dr. Nicole Alexander-Scott, the Director of the Rhode Island Department of Health, to brief us today along with her team. So Director, thank you very much. Followed by that, we will have, I'll go back to how we're going to orchestrate the agenda here in a second, a little more detail. Followed by that, we'll have a topic on the Hospital Conversion Act, an overview of the Hospital Conversion Act, and the Attorney General's role as it relates to that act. And we're fortunate to have Peter Neronah, the Honorable Peter Neronah, as our Attorney General here to brief us along with his team. The way we'll operate the committee today, and most of our committees, we're going to have about a 30-minute presentation. I ask the presenters to keep their presentation to 30 minutes or less, followed by no more than 30 minutes or less Q&A period. So the first session will be within an hour's time frame or less. We'll follow that with another session as it relates to the Hospital Conversions Act that Attorney General Peter Neronah will take us through for the second hour or less. So you can plan, we'll be done by 7 o'clock, whether we are done or not. I want to thank everyone for being here today. And with that, I'd like to turn it over to Dr. Nicole Alexander-Scott, or more to Neil Hauton. Neil, thank you for being here as well on the team. Neil is going to walk us through a presentation that we have that's been prepared by the Department of Health. So Dr. Nicole Alexander-Scott, over to you, and thank you for being here. For members of the committee, we're going to hold all of our questions until the end. Thank you.
Thank you, sir. Good afternoon to you and to the members of the committee. We are honored to be here to have this discussion. Wonder how to make it so. Can everyone see me okay? Or are you just seeing the letter N? You can see me. Okay. So, excellent. I'm saying we because there's a tremendous team who has joined in to support our discussion today, and I'll be sharing the wealth in terms of this important presentation. Ana Novais, who's one of our senior leaders. She's Assistant Secretary for Health at EOHHS and has a tremendous level of expertise as a prior Rhode Island Department of Health Deputy Director and beyond. And she's continuing our focus on our healthcare system reorientation and health system transformation. And so we've appreciated her leadership. Everyone knows Neil Hauton, who's our legislative liaison extraordinaire. And then we have our excellent team who's focused on our health systems policy and regulation. Sandra Powell is the division director. Mike Dexter is the center director. And Fernanda Lopes is the lead for the program. So Neil's going to kindly share the slides, and I'm going to get us started with the introduction of what we're going to focus on, and then be able to hand it off to my colleagues. I also want to recognize Jackie Kelly, who is one of our senior leaders who's been invaluable to the department in so many areas, but is also joining us to support our work here tonight. So the two topics that we will get through and keep to our half hour or less time frame is to start with the Rhode Island Health System Transformation Vision, because number one, it aligns with the strategic priorities that we have had as a department, as well as across our Executive Office of Health and Human Services Secretariat, allowing us to really emphasize the fact that health happens within and beyond our healthcare system. We like to say that the healthcare part makes up 10% of what determines in terms of how healthy someone is, and being able to focus on those elements in the community that also contribute to health based on determinants of health is a key element of our health system transformation vision, and helping to use that understanding to shape what we're doing with the healthcare system specifically is a critical component. And we're going to then get into the regulatory framework so that it's clear how one of the many levers that are available to us helps drive us in the direction of health system transformation that we are looking to go to. So with starting off with health system transformation, I want to pass it on to Ana Novais, who can take us through the next few slides and really set the stage for what we're talking about.
Thank you, Director, and thank you, everyone. Good afternoon, and thanks for having us here today. I am so pleased and honored to join my colleagues and friends, on a sense, long years of working together to have this conversation. So as the Director said, we wanted to briefly set the stage in terms of how our health system, our vision for that health system, how it's been impacted, and what role the Department of Health, Health Systems Council, the regulatory oversight of that system can help us move forward a vision and get the health system where we need the system to be. COVID, as we've seen so well for the past, unfortunately for the past 10 months, almost 1 year now, have exacerbated the cracks in our system. It's shown us the things where we were doing well, but it also brought very clearly the areas that we were needing to focus and improve. The disparities in the underlying determinants of health became evident with every passing month of the COVID response. Issues around delayed or abandoned treatment, which drives negative outcomes, became also clear as we saw what was happening in some of our communities. We saw how much the capacity of solvency of some providers, hospitals, primary care practices was also impacting. And then the lack of a comprehensive emergency public health preparedness, but on a sense of coordination and integration across all of the systems. It also helps us accelerate progress in where we need it and in certain areas. We were able, for example, to increase the uptake of telehealth, and which was an expansion of how we deliver health into the people that need it. We saw an increased interest in coming up with alternative ways of having payment models being experimented in our system, and we did that with our primary care capitation. We saw a reduction in avoidable hospital and emergency department visits, something that we had been working in a long time, and by default, maybe of the pandemic, we saw that people end up going really when it was absolutely necessary. And we saw definitely an enhanced system-wide coordination in ways that we hadn't seen before. So the next slide, Neil, shows just some areas where we were doing better than average, and I'm not going to read it, but all of them, and the areas that still we need to improve. The areas around the avoidable use and costs, that's one that we need to improve, both at the national and among the other states. Our hospital admissions for what we call ambulatory sensitive conditions, meaning things that if treated in a timely manner would not be needing to be lead to a hospital admission. The avoidable emergency department visits, as we referred to before, people who seek care, routine care at emergency departments, those are areas that the data showed us that we needed to work on. And then we are doing, based on those things, really, how do we reorient the health system in our state So we pay attention to, as the director was mentioning, to the social determinants of health, those things that we know impact one's health outcomes that happen outside of the health system, but impact what happens within that healthcare system. Issues of, we could focus on housing, on education, on the community and social connections and supports that one need, having good jobs, healthy food, access to transportation, all of the things that then impact the patient outcomes that are at the center of our health system, and also what happens within the community. We look at what kind of state regulatory and payment levers we have in order to advance our priorities, and we establish a core set of priorities that we want to move forward, from access to telehealth, as I mentioned, regulatory and payment reforms that foster a more integrated delivery system that improves our population health, that improves our system preparedness, and creates a more financial resilient system. We want to strengthen our preventive and primary care and behavioral health systems and really keep a focus on our health, on outcomes and driving health equity. And we want to make sure to do that we reinvest in our social determinants of health and improving health for all of our Rhode Islanders. And so the last slide I wanted to share with you shows how having that big vision of this viable, responsive, and resilient health system, what kind of near-term levers can we use to move forward the objectives that we set forward. So in terms of shifting spending towards long-term population health, preventive primary care, physical and behavioral health care, we have an opportunity with the FY22 budgets to say how aligned is that budget in terms of those priorities and those objectives. When we looked at in terms of health equity, access in outcomes, and confronting systemic factors that create disparities, and we look at what kind of financial assistance programs and payment reforms can we put in place statewide, not just at the health department level, but statewide, that move those objectives forward. And leading to the conversation today, when we look at promoting our systems preparedness, how do the overall health systems regulatory oversight and statutes, both from the Rhode Island Department of Health and the AG's office, are going to be allowing us to move forward this vision and these objectives. So that's where I will stop, and I will pass it back to Dr. Alexander-Scott to focus on the regulatory framework and role of the department on the Hospital Conversions Act and Health Service Council. Thank you.
Thank you so much, Ana. Hopefully everyone can continue to hear me and see me okay. So we are going to jump in being able to provide some of the detail on this regulatory lever. We're talking first about the Hospital Conversions Act, HCA. It's an application that's required for the Rhode Island Department of Health that I'll refer to as RIDOH and the Office of the Attorney General for the transfer of ownership, assets, membership interests, authority, or control of a hospital. And so what's key here is, number one, what's the role of RIDOH in these hospital conversions? If 20% or more of ownership of a hospital in Rhode Island is to occur, it requires approval by both the Rhode Island Department of Health and the Attorney General's office. And so transfer of 20% or more of ownership will trigger a Hospital Conversion Act review. It will often trigger a change in effective control review, and a change in effective control review involves a review by the Health Services Council. So HCA connects to it in this way. Here are the thresholds for requiring review. Hospital Conversion Act approval is required when there's transfer of 20% or more of ownership, assets, membership interests, authority, or control of a hospital. HCA approval is required by both RIDOH and the Rhode Island Attorney General's office. That is distinct from change in effective control approval, which is required when there is transfer of 50% or more of ownership, assets, membership interests, authority, or control of a hospital. And approval is required by RIDOH based on recommendation from the Health Services Council. So the HCA, 20%, and includes the Rhode Island Attorney General's office. Change in effective control, 50%, and includes the Health Services Council. So, purpose of the Hospital Conversions Act. 5 key elements intended to assure viability of safe, accessible, and affordable healthcare systems. To establish the process to review whether for-profit hospitals will maintain, enhance, or disrupt the delivery of healthcare in Rhode Island, and to ensure that we're monitoring hospital performance to meet standards for community benefits. Also, it's intended to establish a review process and criteria for review of hospital conversions. It's also intended to clarify the jurisdiction and authority of the Department of Health to protect public health and welfare, and the Office of the Attorney General to preserve and protect public and charitable assets in reviewing both for-profit corporations and non-for-profit hospital conversions. For the Rhode Island Office of the Attorney General only, the purpose is to provide for independent foundations to hold and distribute proceeds of hospital conversions consistent with the acquiree's original purpose, or for the support and promotion of healthcare and social needs in the affected community. And that's something that the Attorney General's office is specific to. When you dig in deeper on the RIDOH HCA review criteria, these are the following that are needed. RIDOH must determine if character, commitment, competence, and standing in any communities served by the proposed transacting parties is satisfactory. RIDOH also must determine if sufficient safeguards are included to assure continued access to affordable care in the affected community. Also must determine if transacting parties provided clear and convincing evidence that the new hospital will provide health care and appropriate access for traditionally underserved populations. And determine if procedures or safeguards are assured to ensure that ownership interests will not be used as incentives for hospital employees or physicians to refer patients to the hospital. And determine if transacting parties have made a commitment assuring continuation of collective bargaining rights, if applicable, and focus on workforce retention. So a number of review criteria. It continues with ensuring that RIDOH determines if transacting parties accounted for employment needs and workforce retraining needed. Also determine if conversion demonstrates the public interest will be served, considering essential medical services needed to provide safe and adequate treatment, along with appropriate access and healthcare delivery to Rhode Islanders. Also issue market share that affects quality, access, and affordability of services. And for the for-profit facilities only, the acquirer must demonstrate that it has satisfactorily met terms and conditions of approval for any previous conversion application. In terms of the application timeline, the same application is submitted to both Rhode Island Department of Health and the Attorney General's office, but they conduct separate yet concurrent reviews. Upon submission of applications, both agencies have 30 days to review the application to determine if it is complete. If incomplete, transacting parties are informed of the additional information that's required, an iterative process until that has taken place effectively. Transacting parties have 30 working days to address deficiencies and resubmit the application. Upon resubmission, both agencies have 10 working days to accept the application as amended or reject without prejudice. And an important component is that steps 2 through 4, as I was alluding to, may be repeated if the application is not deemed complete upon resubmission. So the timeline that starts where it is can certainly extend out pretty significantly if additional information is needed. Once agencies concurrently deem the application complete, the review is started. The Rhode Island AG has 30 working days from the date application is deemed complete to make confidentiality determinations. Then both agencies have 30 working days from the date the application is deemed complete to notify the public and provide an opportunity for public comment. An informational public meeting must be held within 60 days of public notice, and decision of agencies are due no later than 120 days from the date the application is deemed complete. So a number of days or weeks may go in between determining an application is complete, and then these number of days up to 120 days are allowed until the decision of agencies is due after the application is complete. This timeline helps describe that again, and it's key to see the two categories where the first half reflects the steps that could be repeated as necessary until the application is deemed complete by Rhode Island Department of Health, while the AG's office goes through a similar process, and then the subsequent 120 days that can occur until the decision is due after the application is complete. So the role of the community is something that RIDOH has valued significantly. Public input is sought through written comment and informational public meetings. RIDOH and Rhode Island AG's office will hold at least one informational public meeting in the hospital's community. And under the Change and Effective Control Review, the Health Services Council reviews the application at meetings that are open to the public as well. For experts that are used, the law permits agencies to engage them to assist in review of financial viability, quality of care, and character of the transacting parties. There's oftentimes a tremendous amount of information that needs to be culled and analyzed and interpreted. All reports prepared by experts are made available to transacting parties and to the public. Experts may present findings to the Health Services Council, and costs of experts are the responsibility of the transacting parties. For the RIDOH form of the HCA review to make its decision, the Rhode Island Department of Health will consider all elements of the application process, including information from formal application materials, information from comments presented at public meetings, information from written comments received from interested parties, as well as information from the experts' findings and reports. For the decision and conditions as a result of its HCA review, RIDOH may approve. The application may approve with conditions or deny the application. RIDOH and the Rhode Island AG's office have the authority to include conditions of approval that connect to the purpose and review criteria. So with that, I want to quickly go into the Health Services Council for the change and effective control applications. The proposed change of owner, operator, or lessee of a healthcare facility is intended to transfer governance, operational authority, or controlling interest in ownership for governance of the healthcare facility. The Health Services Council used by RIDOH is intended to have review criteria that also looks at character, commitment, competence, as well as financial viability, safe and adequate treatment, and appropriate access with respect to traditionally underserved populations. Similarly, the process involves a separate application from the HCA application, but is filed only with RIDOH. Once the application is deemed complete, RIDOH will notify and give the public an opportunity to comment. Meetings held before the Health Services Council and all application materials are public. Change in effective control approval is required from RIDOH with recommendation from the Health Services Council, and department decision is due within 90 days from the date application is deemed complete, and the time frame often is extended to coincide with the issuance of the HCA decision, given the 120 days associated there. And conditions of approval may be recommended by the Health Services Council via the change in effective control process. So importantly, the Health Services Council is an advisory body to the Director of Health. There are 12 members, 4 appointed by the Governor, 4 by the Speaker, and 4 by the Senate President. This is an example of who we currently have in place according to the 4 represented positions for each of the 3 categories that are in place. And so I am going to stop there. You can certainly leave it on the last slide, the prior slide, Neil. We do have in the appendix some examples of application types and prior applications. It's also important to be able to say up front as we go into questions, the notion that I cannot testify about a matter in which I, as the Director of Health, may have to render a decision. So I wanted to share that in advance. Even if I am familiar with the topic, anything I say may be perceived out of context or give the wrong impression of my position. And so I'm going to withhold any comments on any current applications that is in place, and I want to fulfill my duty to fairly consider any dispute that I must resolve without discussing that in this situation at all. So I want to thank everyone in advance for honoring that with me. And I shall give it back to you, sir. Thank you.
Director, that was phenomenal. And Neil, well done, because Neil and I had talked. I said at 30 minutes we would probably cut you off, respectfully. And based on the time we started a few minutes late, it's 5:31, so job one, well done, Director. So I want to open it up to the committee for questions. And I'd ask the best way to do it. I can see you. You want to put your hand up, or Senator Coleman. Go ahead. Just make sure you unmute yourself and.
Thank you so much. And I'm actually not sure. I really appreciate the presentation. I'm not sure if this question is like specifically germane to the presentation, but I think it's more of a general thing. Some of you may have seen in the Boston Globe today, there was a story about the extent to which, so there's, the federal law requiring transparency between hospitals and about rates negotiated between hospitals and insurers. And I was curious, this is a transparency sort of act in general, and I guess I was wondering if there is any consideration of that issue. And the Globe article today was about enforcement of that transparency and how it's been very spotty around the country, et cetera. And so I guess I am wondering if that is contemplated in any way in this emergent thinking, both about just in this context.
I want to open it up to the team to be able to answer, whether Jackie Kelly or Mike Dexter or others have thoughts, and then I can also add a response.
Yeah, thank you, Director. This is Mike Dexter. That is a little bit outside of what we're talking about today. I believe that is something that is not provided for in Rhode Island law or regulation. It is something that you would find that the Office of the Health Insurance Commissioner would be in their domain. Thank you.
Thank you, Michael.
So the thing I would add to that and welcome Ana or others to provide is we have worked hard to ensure coordination across the Secretariat specific to health system transformation related items such as these, particularly given the different levers that we have. And so our work with OHIC, also our work with the AGs, is one where we are continually communicating to see how we can achieve some of the enhancements, as you ask about, that's been in place today. I would need to get some more information to answer more specifically on what you have asked about, but certainly we are constantly looking for ways to be thoughtful about the conversations that happen between healthcare facilities and their role with oversight, with financial management, and with the healthcare system as a whole.
Director, thank you. One question that will go to other senators as well. With regards to one thing that was maybe address this in a different way, one thing I thought was conspicuously absent was the certificate of need. I didn't see anywhere mentioning certificate of need as I always look at the CON, the certificate of need as the major driver. Any reason that wasn't mentioned, or is that overarching everything you said?
No, we certainly could have included that piece. We wanted to respond to what we understood was a focus for this. But the certificate of need is a key component, particularly with establishing a new healthcare facility that includes hospitals, but also expands to existing healthcare facilities or establishing additional new healthcare services or equipment. So that can be an additional discussion where we talk about new hospitals as well as additional types of healthcare facilities and services that are involved. And we'd be happy to share further on that as well.
Let me just pull that thread, I guess, once more. And if we can go to, you don't have to go to slide 20, but on slide 20, we talked about experts. And going back to the certificate of need, and thank you for providing some of the material ahead of time. We'll get it off all the committee members to look at subsequent. So you recently had a decision that certificate of need, you went off, you hired an expert, the Faulkner Group, to come back and say, tell us what you're going to tell us. And at the end of the day, a different decision was rendered. So in light of the certificate of need, that was a new facility, not necessarily the 20% or the 50% that would kick in for the Hospital Conversion Act. Can you talk a little bit with regards to, we hire experts, they give us their opinion, we pay for their services, we don't necessarily follow their recommendation.
Yeah. That simply refers to the fact that the expert input is one of the many critical inputs that we have to take into account in rendering the decision. So the experts provide what we need. We're also taking the comments from the public. We're also taking the information from the applications themselves. We're also taking what comes of our coordination with the AGs when that applies appropriately. And so really have to undergo that complex process of balancing that information, knowing that the expert component is heavily weighted, but is not the sole determinant for making an ultimate decision.
Thank you, Director. Other questions from committee members? Senator Acosta.
Thank you, Mr. Chairman, and thank you, Dr. Alexander-Scott, for your presentation today and for the millions of presentations you've been having to give. Just a quick clarifying question. Am I right that, so the thresholds are 20 and 50%, but the way that the law is set up in the breakdown you gave, the RIDOH and the AG's office kick in for the 20% threshold, but only RIDOH works for the 50%, or do I have that flipped?
No, you said it correctly, and it can become challenging to understand, but RIDOH is involved in both, but when you get to 50%, then we also have to pull in the Health Services Council in part of that review.
So does the Health Services Council then supplant or move out the AG? And so in this case, the AG only works on applications between 20 and 49%?
The Health Services Council does not supplant or move out the AG. They are involved regardless, and the 20% on. It's just that if there is something that's the 50%, then the Health Services Council gets to is pulled in as well.
Got it. Thank you.
Want to let anyone from the team be able to offer any additional clarification too. Otherwise, we can keep going.
For everyone's benefit, Director, please correct me if I'm wrong. I know you will. The Health Services Council is a legislative creation, basically. Mm-hmm. You'll find that in Rhode Island general law as indicated with regard to the Health Services Council. So we as a General Assembly create that to help facilitate the work of the Department of Health for the things that they need. So, other questions by committee members? Senator Dela Cruz. Senator, you might still be on mute. You're not on mute, but we can't hear you. Wait, we'll give her a second. There we go.
I think I may have to do my committee work from the State House because I've got 3 boys at home. So forgive me there. Thank you, Senator DePalma, Chairman DePalma, and Dr. Alexander-Scott and your team members for the presentation. It was very informative. I did learn a lot. I have to say, the Hospital Conversion Act, there were aspects about it that I just didn't know, so it was very informative, and I very much appreciate it. Which is not germane, as Senator Kalman had mentioned, is at some point I would like to talk about what's happening in the state with the COVID and the vaccines. I know this isn't the presentation that we have, but at some point I think we need to have that discussion.
Other questions by committee members? So Dr. Scott and Michael, I think you've probably been most familiar, Michael, since you facilitate a lot of the work done by the Health Services Council. And looking at Rhode Island general law as it describes the work of the Health Services Council, if you were to say one area that needed change, and I'm not asking you for specifics necessarily, but 1, 2, or 3, can you briefly tell us? Because one of the things that we're looking at the rules, ethics, and oversight as a means to, number 1, better understand what's going on. Number 2, figure out what's working well. Figure out what needs to change. And so this question here, Director Michael, from your intimate familiarity in working with the Health Services Council, if there's one area that you believe needs change within the framework of the HSC, what is that?
Well, I'll start with saying the Health Services Council process had been updated relatively recently over the last several years within the time that I've become director. And we have been certainly pleased with the overall engagement of the council and the smaller focus and ability to really dig in and provide the input that's needed. Some of the aspects that always benefit from ongoing improvement is continuing to focus on ways to more deliberately advance the diversity of the council. Certainly from a race ethnicity standpoint, always from a gender and other abilities standpoint, but then also in terms of the varying representation of communities, particularly when you look at which communities the current hospitals and healthcare facilities are in. We always want to ensure that the people on the council are direct reflections of the communities that those facilities serve and exist in. So those would be some of the feedback and just something we are working on together currently to improve.
Okay. So, Director, one of the, because it was going to be my next question, but you led me there, so I'm glad you articulated what you did regarding the composition of the committee, of the council. When we look at the, I suspect, I don't suspect, I think I know, the folks that are on the council are very highly sought after, given their capability and capacity and experience, probably built into capability and capacity there. And looking at some of the various meetings that have occurred, there are many times where folks need to recuse themselves because they're so much sought after that there's a conflict of interest. So maybe tying that in, and maybe I'll ask if Neil can follow back with us about some of the, I'm not certain it was in the information that you had sent, Neil, with regards to, so you have the meetings pretty, from what I've looked at in the past, meetings are pretty well attended for the most part, but then you have 2 or 3 recusals, and was it 11 folks on the commission or 13? However, I think it's 11.
Yeah, right now there's 11 seated. Thank you.
Okay, and so if 3 or 4 are have to recuse because of a conflict of interest, you're down to potentially 5 folks that it could be, based on there being a quorum, that a 3-2 vote can be rendered on something that can be major. So whatever help you might need there, please let us know to try and figure out how to improve the operation of it. Knowing that folks are nothing against the folks, they're very well sought after because of their capability and the capacity, but if they're not able to help you in doing what you need to do, that becomes a challenge. Other questions, comments, thoughts? I have one last question, Commissioner. Director, rather. I know there's times when you can do an expedited review. What are the criteria for doing an expedited review, and have we had any in 2020 or in the past that you can talk about a little bit? And you don't have to use all 14 minutes left by any means.
So we actually have some slides on expedited review in the appendix that we can share. There are certain situations when the review may be granted to not-for-profit hospitals that RIDOH determines to be distressed. Distressed can qualify if there is an operating loss for 2 of the most recent fiscal years, or if there's less than 50 days cash on hand, or if there's current asset to liability ratio of less than 1.5, or long-term debt to capitalization that's greater than 75%, or an inpatient occupancy rate of less than 50%, or it's classified as below investment grade by major rating agency that exists.
Okay.
And so the concept is that the application process can be shortened. That's submitted to RIDOH and the Rhode Island AGs for expedited review. But the next slide will show that shortened is sort of a figurative interpretation. So agencies still review the application to determine completeness. If incomplete, transacting parties are informed of the additional information that's required by agencies. And similar to the full review process, it can go through a repetitive exchange until the application has what's needed to be deemed complete by both agencies. Once the application is deemed complete, agencies notify the applicant and give the public an opportunity to comment. And then agencies must notify the public and provide opportunity for comment within 20 working days from the date the application is complete. So that's one of the places where it's shortened. And the decision of agencies for approval or not approving or approving with conditions is due within 90 days from the date the application is complete, as opposed to the previous 120 days. So it's still a decent amount of time in the long term, but considered somewhat shortened compared to the full.
Director, thank you very much. Other questions from the committee? So, Director, when was the last time the expedited process was used?
I'm looking at our list and seeing if Mike wants to, or Fernanda wants to jump in to answer. Otherwise, we can get back to you on that.
Just trying to get.
Yeah, as far as the conversion, I believe the Yale Westerly hospital conversion was done expedited. That was a few years ago.
Okay.
Thank you.
Other questions from the committee? So, Dr. Scott, just before you leave, I do want to thank I should have done it sooner, and I didn't. I want to thank the members of the committee that are here. Senator Seventies, Vice Chair, Senator Coleman as Secretary, Senator Acosta, Senator Archibald, Senator Del Cruz, Senator Royer, and Senator Lombardo. I think I got everybody. I want to thank Kat for all the work she's done in putting this together, Lisa Collier, and Kristen, thank you very much. So, Director, thank you. I'm sure we'll be talking about hospitals in the near future.
Yes.
Thank
I want to also offer my thanks to you and to the committee for being focused on this and being a partner with us and helping to ensure Rhode Island has the health system setup that we know is needed and most beneficial for our residents, and also want to offer tremendous thanks to the team who have joined with me and have done an amazing job in the midst of the COVID pandemic response to help make sure that we are ready for this and stand prepared to go forward with what is needed. And then also just want to acknowledge our colleagues in the AG's office and say thank you to you as well for just being invaluable partners engaged in this, and want to offer my or ask for some graciousness, because I would otherwise stay and support, but today is my husband's birthday, so I need to get him some cake and be able to celebrate for a few hours.
Director, thank you very much. Thanks to your team, and I should have said earlier, thanks to Neil. We call Neil, we text Neil, Neil calls us back, Neil texts us, and he has the answer. So we like Neil.
That was amazing.
Yeah.
Yes.
Thank you. Thank you very much. Thank you.
Take care.
Have a good evening.
Thank you.